So good morning, everyone, in here and out there. My name is Teresa Bernardo. I'm an epidemiologist and chair of Emerging Technologies and Preventive Healthcare at the University of Guelph in Canada. I've been asked to remind everybody that the sessions are being recorded and will be posted online. And please, everyone in the audience, state your name and affiliation when you ask a question and use the microphone so you can be recorded. And for virtual presenters, confirm that we can hear them and see their slides. So we heard several calls yesterday for inclusion of a greater range of stakeholders and work across disciplines, especially the social sciences. And we're off to a great start thanks to Dr. Omer's presentation. We're going to continue with session 3 on social and behavioral strategies to motivate acceptance and uptake of public health recommendations. And this is in 3 sections: civil society, individual behavior, and communicating research. So with that, I'll turn it over to my colleague, John Parrish-Sproul, who will moderate Part A on civil society.
No?
That's good now.
Good morning. Yesterday, as we finished our conversations, I thought it was extraordinary that a number of people across the range of scientists talked about the importance of communication, issues of building trust as really a critical area which we didn't perform well, and we need to do something more. And this, of course, was underscored by Dr. Omer's presentation a few moments ago. I would have to say then that I was sorely disappointed when they talked about action points, that nobody talked about creating a global, national, and local and provider strategy that would seamlessly work together to help us in the next era. We talked about research and we talked about other areas. Given that importance, I would think that we'd want to do that. Our speakers today speak to the importance to that and why we need to do that some more. And so extending on what Dr. Omer said, we first of all have Dr. Naveen Thakur, who is the president-elect of the International Pediatric Association, and he will speak to what they have been doing with respect to trying to prepare people to deal with the issues of trust and communication.
Thank you so much. Can I have my slides, please? Okay, and how do you? Yeah. Okay, so thanks for the invitation, and I bring you greeting from International Pediatric Association. I don't know how much you people utilize the expertise of Saad Omar or Professor John, but we utilize that very well. And way back in 2018, we engaged with them, and I will today my presentation, very brief presentation on 2 parts. First is what we did as International Pediatric Association. Everything what he said, medical professionals are trusted voice, but they lack communication skills. And here you had a best expert in US, which we reach out, and we how we interconnect between scientific community and behavioral and social science community. We did that. And second part is some of my involvement in India, which has the biggest COVID-19 vaccination campaign, and also where Delta was born. So how we dealt with that, and some experience on that. So International Pediatric Association is 112 years old global body representing 165 member societies from over 149 countries, representing 1 million pediatricians, and there is only one global society. American Academy of Pediatrics is also our member society, and everybody is happy to work under the one umbrella organization for more than 112 years. How do I move that? Yeah. So This is a story about online IPA vaccine trust course. And you can see the statistics here. We have 7,546 registration till now from 149 countries. And 1,962 people have completed all modules, because we count course completion when they complete all 7 modules. And then 1787 are in progress, and many did not start. Then we do a 3 months follow-up survey. Here you can see there are 7 modules. Everything is here which medical health professional need to know. And none of the module is prepared by a pediatrician. And Saad is also not a pediatrician. He told me once, but we engaged with him. So these are the modules, all evidence-based. Infodemiology prepared by CDC and WHO, behavior science, Saad Omar and Rob Butler, interpersonal, Dr. John and Angus Thompson, social media by Jaden Consulting, all experts in the best experts in the world. Vocal vaccine denier from Europe, interacting with media by a journalist who had experience. And let me tell you, there are evidence-based technology. How do you deal with media? And we heard that first time. Blocking and, there are so many terms which we never heard. And they are all evidence-based technology which we cover here. And last was advocacy from IVAC. Now, how did it start? It started, I was on Gavi board representing civil society organizations, and we heard in 2015, the vaccine hesitancy, it was being discussed in board, and somehow I have intuition that, what will be needed in future, because my lifetime work is on polio eradication. So I started working on this through IPA, because I finished my term by that time in Gavi board. So we had this first international training of trainer, and I remember when I first planned this, I have thought the names of all great pediatricians who are my friends, including Walt Orenstein and others. And that time, first time I was told, Naveen, if you want to work on vaccine hesitancy, you don't need pediatrician, you need an interdisciplinary team. And we assembled this team, and we had first TOT, which was supported by Serum Institute and Sanofi Pasteur. So we trained from 26 countries, these much people. Then officially, WHO declared vaccine hesitancy as one of the global threat in 2019. We had a second training of trainer in Panama, Panama City, where we had our conference, where again, a lot of countries around the world and from Latin America participated, and Saad Omar was there. You can see him in the middle. Then suddenly we had a plan to go region-wise and do the prepare trainer, but suddenly COVID came. So we also, we had mRNA platform working, was going on, so we had something ready. And I knew that this is very useful, because once this happens, first people they contact for vaccination are pediatrician. Not in US, you may have adult vaccination, but in other parts of the world, it is only pediatric vaccination. And even in COVID-19, as I said, I was helping with government. So we converted that. Here are the, you can see the enrollment. This is already published, so I will not go into detail, just to give you some, we had all data, a pre and post training survey, and it was found very useful by the people. And we received all this feedback. Again, I said, as this is part of the just published 4 days back. So you have all the data available, and I have been shown the card that only 1 or 2 minutes are remaining. So maybe we can discuss. So cognitive domain, you have all the data, how it worked, and it is now published. We have hundreds of testimonial on our website from nurses, from the pediatrician, from the other community, how they found useful, because this was timely. This was people needed this to talk to people, and that's why this was very successful. And as I said, it was from the 147 countries, which even the IPA has not reached 140, not reached to so many countries, not even member. We could reach there because we were first to launch this, which was suddenly something was needed. So shifting from give me 1 minute only. Shifting face-to-face online training, we could increase global reach. Online course was made more optimal experts. So whatever was recorded in those workshops, we translated and also recorded something more. And you can see the health workers found this very, very useful. Another thing what I want to say about the collaboration, that we launched this COVID vaccine solidarity campaign even before vaccine was launched, and it was only 30-second to 1 minute video we shot from the different countries and put it and in different language, and we circulated, which was very, very effective. It was just saying, if I get vaccine is available, I will take it tomorrow. In Turkish, in all the languages, we did one video and then we circulated. Now, coming from learning from the India, you can see here, I was first person to be given vaccine in Gujarat. And you can see here in the second picture that behind me, there are around 150 journalists. I offered to, because I was advising Chief Minister, and I offered and I was called. And I never knew that giving one shot can make you celebrity overnight, not your work of 20 years or 20, working continuously. And I was chased by reporters for next 7 days. How you are feeling? So there is a very famous video which has, which posted on Twitter. I am on my bicycle and I say that, I have taken vaccine and I'm feeling all right. And that was, you can see the Chief Minister giving me a medal. I don't know, it's a badge, but it's like never ever in my life I became so popular and everybody, household name by just taking a shot. So that's the power of vaccine. We prepared, this is through our Child Health Foundation, we prepared the social media kit and translated in language, which was, everybody says that medical professionals are trusted, and that is true. I knew that when I was working on polio, even before, people were at that time talking about that religious leaders are more effective. But when it comes to the health matter, every family is connected to a practitioner. He may be qualified, he may be unqualified, but that's the final voice. Recently, Gates Foundation has published my blog about polio, my life journey on polio, and Mr. Bill Gates also tweeted that. So again, it reaches to so many things, and that's where I have written how a given commitment to a Muslim family from a doctor could only work, not anything else. You please do, it's on the Gates Foundation website. Only 30 seconds more, madam. Vaccine safety, these are the concern. People have genuine concern. And if you address that, they are happy. Then don't call everyone as a vaccine hesitant or vaccine denier. They have concern. We published, we instead of publication, we announced in the press conference. We talked about efficacy for what? For clinical disease. Yeah, I know that trials were designed such way, but did we convey that we don't have data on the efficacy against hospitalization, death, and serious disease? No, we realized that quite late. You people are lucky you got vaccine, which was 90% effective, but what about the other people who had vaccine, but they were waiting? Even ministers were asking me, can we get the Pfizer vaccine? So you can see how much that affects other parts of the world where you may have other vaccine, but that all is effective in serious disease, death, and hospitalization. How many months we took in conveying that? Safety concern, doubt about efficacy. We started vaccinating when Delta was already spreading. People were getting disease, and they said if you take within 2 weeks, for next 10 days you may get COVID. Misinformation mutates daily. Daily it mutates, and you have to keep pace with that. You have to see that what's happening and address accordingly. You cannot just go on changing schedules. We change schedules many times from say 4 weeks to 8 weeks and 6 months and again back. That really hurts. Lack of trust. It was never, nobody clearly assured that it is safe in pregnant and lactating women. And we started discussing science on Twitter. It is first time we stopped all these meetings and we started discussing, and many people have, all the professors from WhatsApp University, where they were called on, anybody who was accessible was on television without knowing how much damage they were doing. So there were other issues. And so what works? This is final slide. So honest and transparent communication, that is two-way. You have to understand, you listen to the community address and concern. Misinformation mutate like virus and travel in real time. Sometimes I get a message that, this happened in India and our prayers are with you, and I don't know what has happened because, if somebody from US writes you, and if you are late in seeing the news, you don't know why you are. So misinformation also travels in right time. Community mobilizers should be equipped to convey uncertainty with total honesty. That's not only the president, not only the politician. Everybody should be taught how to do that. Designing a strategy based on principles of behavior science, and we learned from Saad and everyone, and we thought these messages are important. We have a quote from Dr. John, Professor John, who says, it is not important what do you say, it is more important how do you say. We wanted to reach that message to each and everyone, and we utilized that. Saad Omar said, people take decision not based on evidence or but based on their perception, beliefs, and attitude. We wanted that message should be conveyed to everyone. Involved trusted voices, as I said, medical professionals are still the trusted voices, but they lack those communication skill, and that's what we provided. So that we provided, but it's a long journey. We had limited funding, but we had practically everybody was on our project advisory committee. WHO, UNICEF, CDC, and other Europeans, WHO European region, everybody was there, Gavi, and it was guided. Then digital literacy is very important, and a lot of work is being done in India, and I think in other places, but it's really just a drop in the ocean. Fact-checking, workshop, webinar, good effort, but we have to invest more. My favorite quote is that India did everything, including mock drill. I don't know any other country has done mock drill, but we did 2-3 mock drill for vaccination, everything like dry run, what they say. But we failed to read the people's mind. We have not invested in communication as we have invested in vaccine. And there was yesterday, I could not ask the question, how much we have invested on communication? Make data available in public domain. The days are gone when you say, I'm a scientist, I'm saying, and you listen it. No, people want to say data. And that did not happen in India also initially, because the subject expert committee passed the particular vaccine, data was not available, and it's a democratic country, and overnight there was, explosion of misinformation and genuine demand that where is the data, how you can do that. Rapid review of data related to AFI. Sometimes we feel there are so many AFI, you cannot counter misinformation if you don't have rapid review, and it takes many months in India and many other countries where before the data is reviewed. So that's very important. Sensitized media. Media is not trained in the science communication. They will call anybody who is known to them, or any pediatrician who is treating their child, and call them on TV, and they will speak whatever they want. Media should also be, trained about efficacy, effectiveness, efficacy against what, and all these things, variants. So they will do whatever they like. So as I said, this article is published now in Vaccine. It is very much available for free download and sharing. Please go ahead and do that. You can see this is how this collaboration was built up. You have best speakers, Noni, led by Walter, and other people from Australia to Canada and from everywhere, and you have all the organization here and supported by industry. So industry is happy to work with us. These people are happy to work with us if even they don't work together. We are happy to collaborate, and thanks to all these people, we could do this, and we continue, and we have our what we call third vaccine trust training of trainer in India in IPA Congress in February 23, and look forward to visit here again. Thank you so much.
You can learn more about our speakers by reading their biographies, but now you already know that Naveen is a celebrity, and so we've got that going on. Our next speaker is Chad Wars, who's the Executive Director and CEO of the American Society of Consulting Pharmacists, and he will share with us his perspective.
Good morning, and thank you. I'm Chad Wers. I'm the Chief Executive for the American Society of Consultant Pharmacists. We are an international organization that represents pharmacies and pharmacists that work in the skilled nursing, assisted living, and older adult community. I don't have any slides, so I'm going to bore you with some statistics. But when the pandemic hit, I'm a practicing pharmacist. I practiced in the long-term care space for 20 years before coming here to lead this association of professionals. But when the pandemic hit, there was somewhat of a lack of recognition of the long-term care community, skilled nursing homes in particular, and the pharmacies, very specialized pharmacies that service them. So just as I know we have a virtual audience as well, but in the room, how many people know what the skilled nursing home environment is like or have worked in the skilled nursing home environment? It's pretty good. I feel like I spent 2 years explaining it to every federal official and expert that we came in contact with, trying to bridge what was going on with the response to the pandemic and the pharmacies and pharmacists out there that were trying to combat the pandemic. Skilled nursing is a very defined population. There are 15,439 skilled nursing facilities in the United States, and I know that number very well because of the efforts that we made to ensure that those individuals were offered access to vaccines and therapeutics. Represents 1.7 million licensed nursing home beds that touch 4 million individuals in this country over the course of the year. We delivered 8 million vaccines to that population to date, 80% of which were delivered by pharmacists. If we look at the current vaccination rates for our population, it just is below 87% for the primary vaccine for both staff and residents, and 45.4% for those that are up to date from a resident perspective, 23% from a staff perspective. And I bring those statistics up simply because they outpace that of the general public. Currently, the up-to-date percentage in this country is 12.7%. If we look at what that means from the perspective of how do we combat hesitancy and how do we get acceptance of things like vaccinations and even things like therapeutics, I think what resonates to this population, number one, is we have to have data, we have to have access, and we have to have trust. If we have those things, we can deploy a system to deliver vaccines and therapeutics quickly and effectively to populations. The beginning of the pandemic, there's a lot of fear. It certainly was targeting older adults. I think there were moments during the pandemic where 40% of the fatalities due to COVID were individuals in skilled nursing facilities. That number has precipitously dropped to be about 15% of overall deaths today, not in any short way from the fact that we vaccinated so effectively on the early goings of the pandemic. But I think what resonates there is that it's not difficult to convince somebody that an older adult with comorbidities that lives in a nursing facility or even an assisted living facility is vulnerable and needs protection. So I go back to one of the statistics that Dr. Omer brought up, which was the 67% acceptance rate for the vaccine. Those are the same individuals that we had to get consent from or discuss for all of the older adults that were living in skilled nursing facilities. So we outpaced even their acceptance rate for their loved one. and that had to do with perceived risk and vulnerability of that population. So when we look at things like what do we do going forward, how do we address the uptake of therapeutics and even the bivalent vaccines, is we need to use data, and we need to use the data that we have to convince people to do something that they may not do for themselves. And I think one of our challenges with the medical community is doing just that, is that it may not be right for a 50-year-old physician that's working in a skilled nursing facility. They may be hesitant about getting the bivalent vaccine or using Paxlovid to treat their COVID positive situation. But they need to make a different decision for an 85-year-old living in a nursing home or an assisted living facility with a different array of risk. And I think if we look at one of the failures, and I've heard some of the questions and some of the speakers, one of the failures has been to deliver accurate data that we can then translate into communication for both individuals, residents of nursing facilities and their loved ones and caregivers, but also to the medical professionals. We've failed at a grand scale of that. And even these statistics that I'm citing, these are all publicly available statistics. They're very broad. We talk about death rates, case rates with respect to the different skilled nursing communities versus the public. But they're powerful because they do lend some weight to why we might take different decisions for targeted populations. 93% of the deaths due to COVID right now in this country are individuals over the age of 50. 804,000 of the deaths are over the age of 65 in this country, which is 75% of all total deaths due to COVID. And those kinds of statistics, I think, are powerful when it comes to convincing somebody to do something for those that are vulnerable. A couple of the other things that I'll mention before coming off is we talked about at the early part of this dialogue that skilled nursing facilities they're a small population, but they're not small when you consider how they relate to hospitals and hospitalized patients. And they are very vulnerable groups of individuals. And we have to continue to capitalize on the things that we did during the pandemic, the flexibilities that we authorized to different disciplines in terms of scope of practice and generating access of therapies and vaccines to people. We need to do that going forward. And I know Dr. Omer made the comment that this is not the fun time to think about the next pandemic, but the reality is there were a number of things that we did that would speed access and availability of vaccines, labs, therapeutics to individuals, especially at-risk individuals, for the next pandemic if we capitalize on what we learned from this past pandemic and we keep them in place going forward. So I'll stop there, and I didn't even get to my first warning. I'll stop there and take questions. Thank you.
Thank you, Chad. I think we can see from both speakers some really important issues emerging, and I want to make these comments and try to help us move on to stay on time. And that first of all, it was important that the IPA already had some kind of training in place, and so they were ready to go, and we weren't caught unaware by the pandemic in some respects, and that speaks to the issue that several raised yesterday and that Saad talked about today, being ready for the next one. We have to have that kind of infrastructure in place, and I think that gives us a chance, a glimpse of what that might mean. I think the second thing is when we listen to Chad, is that we know it makes a difference when you reach vulnerable populations, and that echoes what Saad was saying about global equity and trying to get to people who are most vulnerable. And we saw that in microcosm in assisted living facilities and nursing homes, but we also see that in other areas of society where people are highly vulnerable, and the importance of addressing that if we really want to get a handle on these kinds of issues. And so both of those are really important takeaways. We have several questions, I think, from online, and we may have some questions here, but because of the adjusted schedule that we've had, what we'd like to do is take maybe a 10-minute break, make it short, and then we'll come back for the next section.
just before we break, I'd like to take this opportunity because we really want to collect next steps and action steps, which we're going to try to prioritize later in the day. So could I ask each of you for one action step? What would you most recommend?
I think at the beginning of the pandemic, we targeted the most vulnerable patients first with therapeutics. And I think we have to continue to do that during the pandemic. Who is really at risk, and making sure that we provide access to those individuals as quickly as possible, including the infrastructure development and the production and access to the different products.
As well as non-pharmaceuticals, I hope.
Yes.
So I think I have already said that we need to invest more in communication, and we have to very systematically train healthcare professionals and healthcare workers who are in community, in contact with community, in these, interpersonal communication, social media, everything, because, it was an example, but it was a small effort, but, very with some resources, but it has to be done. Like Saad said, you need a national CME, but more than that, a very systematic effort, and I don't still see lot is happening on that front.
And Dr. Omar, would you like to weigh in with your most important recommendation?
Yeah, so invest in the next generation of leaders that come from multiple disciplines that are proficient in the biological, clinical, as well as behavioral science of pandemics.
Excellent, thank you. We're going to take a very short break, so 10 minutes, and we'll start right on time.
Portion of the program, which is on behavior and identity. I would say it says individual behavior, but I think the general principle is that when we need to address behaviors, we need to start by thinking about behavior rather than pointing to causes which may or may not be the primary ones, including misinformation, trust, and so on. And we have two speakers, whom I will introduce right now, both of them, for the sake of time. We have Heidi Larson, who is professor of anthropology, risk and decision science, and the founding director of the Vaccine Confidence Project and the London School of Hygiene and Tropical Medicine, as well as Neil Lewis, who is an assistant professor of communication and social behavior at Cornell University, and also assistant professor of communication research in medicine at the Weill Cornell Medical College. I'm Dolores Albarracin, and I'm the Alexander Heyman Nash University professor at the University of Pennsylvania. And with that,
thanks. Let's see. I don't have slides, and I'll try to keep to time because I know we're running late and have a number of other speakers. I'm giving my few words on what we were asked to look at: the individual behavior and identity. So how the group influences your individual behavior in a sense. And we've heard already a number of references to basically what I see as the power of identity in leveraging individual behavior. The challenges for us is that we've seen in the pandemic that the kind of group behavior, group identity can nudge you to positive health behaviors, but it can also nudge you away from evidence-based behaviors. So the notion of identity by nature is not by itself a positive lever, but it's a phenomena. It's an issue we need to recognize. The other thing is that other issue is that it's rare that anyone has only one identity. We have multiple identities. We heard at one point Saad had referred to a publication on white evangelical. So we've got our racial identity, our religious identity, our professional identity, multiple different angles, and our political identity. The political identity has been, you couldn't hear it more loud and clear anywhere in the world than in the US, how powerful loyalty and alliance to a political identity really drove people to make decisions that were, all the facts in the world were not going to change people's mind over their loyalty and political identity. This was not true for everybody, but it clearly was a powerful lever. As Janet Tobias mentioned in the opening, she talked about my people, and we've heard that in a number of just forums. Well, and I've heard myself in a number of interviews, as one old woman told me, I'll believe it when somebody who looks and talks like me tells me so. And just this idea that, I needed to hear it from one of my own. And really, it comes down to trust. It's about trusted colleagues, trusted relatives, trusted community members, and really the leveraging power of trust. We also see in terms of racial and ethnic identity, and again, you can have different, you have the gender identity in the mix too. In this context, actually, when people ask me about success stories in motivating acceptance of and compliance with not just vaccination, but other measures, I think some of the most powerful and innovative levers of increasing vaccine confidence, for instance, and acceptance have come from within some of these communities in the absence of national leadership. And we've been running a number of, we're doing very large study in a number of countries in the world with research with people's experience during COVID. And it is across, we've been running them in Brazil, US, France, Nigeria, India, and Thailand. And if there's one universal sentiment that's come out of all of these settings, has been disappointment about the fact that the government was really unprepared. But under that, if there's a silver lining, is not, once that sentiment was there, people turn to local networks, local resources, local communities. And that's where I think we've got some really powerful identity levers of positive. In the US, one of the examples that I talk about even in my global work is the Black Coalition Against COVID, Reed Tuckson's really amazing work that had a really impactful measure. And there were a number of aspects of that. And there was even a Black Doctors Read COVID tweets, so that people saw that in their community, there's a trust thing going on there that's really, and the barbers, the engagement of barbers and hairdressers as people that you had a familiarity with. That was another thing, is the heightened uncertainty during the pandemic. Every day, you just didn't know what was going to be next. You didn't know if the data was going to change. You didn't know if the vaccines were going to change. What the, masks, no masks, 3 meters apart or 6 meters apart. you kept hearing a lot of uncertainty. And when you're surrounded by uncertainty, you just want the familiar. You cling to the familiar. And that's where, in this context, it was really powerful. And as I said, it didn't necessarily mean positive levers because it could send you the other way, but it was the heightened uncertainty really begged familiarity. I especially, I saw in the UK, for instance, there were a number of vaccination sites, as in the US, where vaccination was in a tent or in a football stadium or in a performance in a theater somewhere. And we had some elderly people who wanted to be taken for a walk around the place the day before their appointment because why am I going there? That's not where I go to get my vaccines. So any sense of familiarity is a really important aspect of identity and community identity. In terms of religious identity, we also saw that as a powerful mover. And again, it could be in a positive way, but it could be not. We have seen in other instances where overall a religious group, as for in the polio work, for instance, there were some Muslim concerns about the porcine in the nasal vaccine. In the polio and the gelatin around the polio vaccine. So when we had the nasal flu vaccine, which also had the gelatin that kept the flu vaccine in the nose, and I'm only mentioning this because we have nasal COVID vaccines in the pipeline, that even though the Organization of Islamic State signed something with WHO saying we approve it because we recognize that the porcine is far from the pig, so to speak, in the religious terms and the value of life and saving, but that didn't mean that some local imams and local leaders agreed with that. So again, it's the locality as much as the religion, and religious identity in different contexts make a difference. Your religious identity as a minority in a country versus a majority can have very different levers on your individual behavior. You feel you're much more marginalized in some countries, and other countries you're in the majority. And again, that can tie into political identity depending on the situation. The other thing that came strong in our global research in different communities was professional identity. People turned to their employers, their colleagues in ways that were fascinating in a different sense. We saw that, for instance, in the Edelman Trust Barometer, that this was the first year that trust in business and employers ranked higher than trust in government. And when we started to talk to people about that, they felt like, yeah, I mean, we have a community of people we know. They would turn to their employers. We saw this also among health professionals. There were a number of them, depending on what their role was in the response, they became tight support networks. And really powerful levers of decision making. We just finished a paper on the what we call silent refusers, unspoken. It was called Unspoken, and it was about healthcare professionals. Not all healthcare professionals were keen on the COVID vaccine, and they were particularly not keen on any kind of requirement or mandate. But this, again, your health, your decision-making, and your individual compliance was very much finding people of like-minded within your identity community. the other thing we found interesting in our global research with focus groups, in-depth interviews in these 6 countries was some people said, actually, I don't want to be labeled as part of a community. It's stigmatizing. Others said, I don't, it's pigeonholing. Don't put me in a community. Don't identify me with. So on the one hand, which I was a bit surprised by, but I probably shouldn't have been, but to see that label of community, which in a lot of pandemic preparedness reports, when you refer to community, you see it as an asset, a strong thing. And that's not always the perception of people in some of these communities. So it's something that we need to be sensitive about. And the last point I want to make, again, I'm conscious of the time here, is about age identity. And if I were to make a final focus point, if I had a recommendation here, we have a massive issue with our 18 to 34-year-olds, with our younger population. There's a lot of resent among young people. Resent, anger, frustration, mental health off the charts. And it's a sense of lost life in the last couple of years, a resent that they had to do things that was really about somebody else's problem because they didn't feel like they were vulnerable as much. And we've seen it in lost years of education, lost social life, lost a lot of issues. And that anger, that frustration, that depression, that loneliness that went through, we've got a long haul issue there. And it's taken its toll on health, of confidence in health measures. We've just finished a global study that we're comparing vaccine confidence globally in general, not specific to COVID, before and after COVID. We just ran in 2022 a global study, and we see that there's a growing age gap in public confidence. We pretty much around the world, the older and younger populations in terms of general vaccine confidence, or about the MMR vaccine, for instance, was quite relatively close. But we've really seen this gap where actually for older people, there's actually a small boost in confidence, but for under 34, in our case, how we disaggregate it, there's really been a drop, and in some countries it's quite a dramatic drop.
Dr. Larson.
Yes.
Yes. Just maybe take 30 seconds to wrap up.
This is my last point. Yeah.
Thank you.
And just that there are health impacts of this. It's not just about addressing the mental health and the other issues. It is taking a toll on not everywhere, but the health decisions. So I think we have to take that into account, and also recognize that young people, they remind me a lot, have diverse identities themselves. So I hope that was quick enough. Thanks.
Thank you. We're going to move to Dr. Lewis.
Slides. While they're getting it up, I'll get started. Okay. Yeah, they're there, but I don't see. There we go. All right, good morning, everyone. Thank you for the invitation to participate in this panel and to be part of this conversation more broadly. What I want to briefly do this morning is talk about how some of the ways that we communicate or don't communicate about health issues affect people's willingness to adhere to health guidance and recommendations. and how those processes are shaped by the broader context and culture that we find ourselves in the US. I think some of these lessons apply elsewhere, but most of the work I've done is in the US, so I'll focus on that. So these are issues that I've been thinking about since the beginning of my career, when I was first trying to understand some of the dynamics between doctors and patients, and how those dynamics affect whether patients feel like they can trust their doctors, and therefore whether or not they're willing to pay attention to what they have to say. And I did most of that work really focusing on cross-race doctor-patient interactions. One takeaway from that literature on the topic is that people are often scanning their environments to figure out the answer to a central question. That question is this person or this institution worthy of my trust? Does it seem like they're sort of hiding something from me or otherwise behaving in a distant or unusual way that should make me skeptical of them? Or do they seem open to having sort of frank discussions with me about what's going on and what are the implications for my health and well-being? Although time is often scarce when you're trying to address health issues, one thing that I think is important to remember is even spending a few extra seconds to explain the logic of the decisions that are being made can go a long way towards building trust in ways that it can improve health interactions and outcomes. These questions and issues don't only come up in people's minds during doctor-patient visits. We saw them emerge again and again during the pandemic. So to share just one example, because I know we have limited time, as part of a behavioral science task force that worked with the Department of Health and Human Services, as COVID vaccines were rolling out towards the end of 2020 and beginning of 2021. And that task force was assembled because when the vaccines first came out, CMS and HHS noticed that nurses working in long-term care facilities, which I heard a little bit about today, which were mostly Black and brown women, were initially reluctant to take it. So they had early access, but uptake was low initially. And so we worked together to figure out why that was and what we might be able to do about it. When we talked with them to try to get a sense of what was going on, it became clear how some missteps from earlier in the pandemic undermined their trust in the very system that was now asking them to take these vaccines. They mentioned that at the beginning of the pandemic, they were asking for help and support, but were often among the last people to get PPE and other kinds of protection. So it was weird now that all of a sudden the government wanted them to be the first people in line to get this new vaccine. And hearing their reflections reminded me of a lesson from the attitudes and persuasion literature. That's where I do a lot of my research. And that lesson is it's difficult to persuade people to change their behaviors when the messages we're delivering are disfluent or incongruent with the surrounding context and culture. When we kept resources from the nurses in the past and keep resources from other groups in this country, we communicate and reinforce an implicit message that in this country, good things go to the most privileged members of our society first, and people like you are at the back of the line. So even though that's terrible, when things go that way, it sort of makes sense. That's the way things go, and we sort of go along with it. One way that psychologist Norbert Schwartz has put this is, if nothing feels wrong, we nod along. We go along with it because the information we've learned over time has taught us that that's how our society works. When things suddenly change, then the disfluency of the situation creates a sense of skepticism, right? Something feels off that you really have to try and figure out. And that's part of what was happening in that context. The nurses were like, normally we're at the back of the line. Why do you all of a sudden want us to go first? Something isn't right here. If the vaccines were really that good, you'd be giving it to the rich white people first. That's how things typically work. You wouldn't be giving them to me. And so that's a reasonable concern to have, given what our institutions have taught people about who gets what resources in what order. So as interventionists and policymakers then, if we want to change that status quo and improve equity, we have to address that elephant in the room. We have to address those concerns that are on people's minds. Otherwise, they're not going to trust us or take us seriously. And so one of the solutions in that context was to address those issues head on, acknowledge those past wrongs, explain that the reason for setting up the vaccine priorities in the ways that they were was to try and not repeat mistakes of the past, right? So these kinds of institutional acknowledgements matter, and they matter a lot. Saying, look, I know we messed up in the past, we're trying to make it right this time. That acknowledgement and explanation really opened people up to being willing to have the conversations that were necessary to persuade them to get vaccinated. But knowing what to say in those conversations requires going out and talking to people and figuring out what they need. And so, as we prepare for future pandemics, one of the things I think we need to do is ensure that, in addition to investments in the biology and new technology, we also methodologically have to make space for qualitative methods, community-based methods, and other strategies that allow us to dig deep and really understand what people are thinking, and therefore what we need to talk about in those conversations. I'm primarily a quantitative and experimental researcher myself, but these other approaches have been really critical for enhancing my understanding of these processes that underlie health behaviors and health outcomes. They've given me a deeper understanding of how it is that features of social context that we find ourselves in affect how people end up thinking about health and health behaviors in ways that are connected to their important social identities, whether they end up feeling like health behaviors are things people like them should do, and how they end up thinking about and dealing with the difficulties that they might experience in the health system. We have to understand how people are thinking about these things in order to develop effective interventions to change people's behavior and persuade them that we and the institutions we work for, institutions that are developing these health guidance, are worthy of their trust. Thank you.
Thank you very much, both. That was a really great way of kicking us off. And I guess I'll start with two questions, and then we'll move to questions from the audience, both virtually and in person. But I guess my first question, if you had to mention two things and the health system needs to change in order to communicate trustworthiness, because I don't think we should start with how to just communicate without true actions that also meta communicate. What would those two things be? For either of those.
I think one of the things that's important here is to, I know we're always in a rush to get things out, but taking the time to really figure out what people are concerned about, what are their issues, why might they not trust the health system, that is time well spent, right? We can come up with all these kinds of messages that we think are the things that people need to hear, but if those aren't addressing the concerns that they have, then we're going to be stuck and not end up moving the needle. So really taking the time to figure it out, and I think that connects to some of the previous points on monitoring and conducting surveys, doing other community-based work to figure out what people are thinking. That can really help us develop better messages.
Heidi?
Yeah, I think Neil just gave the answer that I would have given.
And what aspects of the health communication strategy now, as you saw it in each country, would you have recommended that be changed or be done differently?
I think we, the next pandemic will be different. We may not have a vaccine as quickly as we did this time. But I feel like we've never before brought the public along with so much exposure to the development process of vaccines. I think a lot of people didn't realize how long it takes to make a vaccine, to go through all the processes. And by emphasizing how quick this was, and then it drove people to understand how long it normally takes, we didn't explain enough. We didn't bring people along with the science as it was evolving. And say that, this mRNA platform, there's 10 years of research behind it. This is a new use of it. But so I think we could have brought the public along more with that. It's always easier to say these things in retrospect. I try to be understanding of leaders that were under considerable stress. But we also unpacked a lot of brands, and that's partly because we had science by press release, not just by Twitter. But some people say this was different because, I just get my flu jab. it wasn't like I get Pfizer or I get Moderna or I get AstraZeneca or and I just get my MMR vaccine. It's easier. It's more straightforward. So we, on the one hand, had fantastic science, but I think that we need to try to bring the public along with it more. And I think we could have done more preparedness in 2020. We knew there were vaccines coming down the pipeline. We didn't know which one was going to make it to the finish line first, but we didn't use 2020 enough. It was really about masking and distancing until we started to have them, and that was a little late.
Yeah, I want to echo that and build on it, that because that whole process thing, it's part of the concerns I was just talking about. And just explaining, taking a little extra time to explain why the process is a bit different now, right? It's all hands on deck kind of approach. It's there are all these things that were different that would give people a reason for understanding why they can still trust in the outcome, even though the process is different. But without that explanation, you sort of leave a lot of room for other things to come to their minds and other reasons for them to be concerned. You know, the language is about how fast we were doing it, that it was, you know, warp speed. Things that move at warp speed are not things we think of as safe, right? So like we have to think about those meta messages and what people will take away from them if we don't give them an explanation for that.
I would just add to the strategy of a lot of the focus on the elderly in the beginning contributed to younger people not feeling like this was really their problem. We had a bit of the reverse situation in Asia where we've had some more resistance among the elderly for vaccination because some of the strategies there were to focus initial vaccination on the productive age group to keep them healthy. So I think to try not to make it a all of society approach and triaging at different places, but to consider the implications of having either an age or gender or whatever focus could have farther down the line.
Any questions from the audience?
Oh, thanks very much. Thanks very much for the overview. I have a question for Neil. The behavioral COVID-19 vaccine uptake behavioral science report commissioned by CMS. The report stated February 2021. So that's in COVID years, we're talking a third of a lifetime. And vaccine confidence, vaccine hesitancy, all these issues they're continuing to evolve. So since that report was prepared and released, what's changed now? What's the current status? What is it as of December 2022?
Yeah, so the report is old, but some of the research behind it, like others have noted, there are lessons that we could learn from other vaccines that were developed in the past, and what happened with those. And so, like one of the things that was highlighted in that report was what business school people talk about as diffusion of innovation curves, that when new things are introduced, you're going to have a subset of people that are ready to get it right away. There's a big group in the middle that are movable or want to wait and see, and then a group of resistors. So part of what happens over time is moving along to different groups. And we've seen that unfold over time, right? That some of the things that were some of the kinds of messages that could get the people who were ready to go, worked really well. And then you had to sort of change your strategy along the way as you're talking to different people depending on where they are. And so over time, you have to sort of figure out where people are and then adjust there. I think the groups that we're talking about, where they've fallen on sort of persuadability has shifted over time. So early on, we were talking about a lot of racial disparities in vaccine uptake, but then once addressing those access issues and engaging those conversations, we moved. And later on, now we're talking a lot about political divisions, right? So I think those are some of the things that have been changing a lot, if that answers your question.
So can we, pardon me, I forgot to introduce myself first.
Yeah.
David Kim with the National Vaccine Program at HHS.
Yeah.
So perhaps an update on the evolving nature of behavior for vaccine uptake by our communities would be in order. Because I think that we're seeing a different we're under a different environment now, and we can see that with a bivalent vaccine uptake,
Yes.
Specifically, and so the evolution of this uptake behavior and personal preference, personal and community obligation issues have changed over the past year.
Yeah, those have changed, and our understanding of, or people's thoughts about whether they need to get them, right? So we're currently running studies now on the bivalent uptake, and it's been sobering that people who got there in a primary series and might have even gotten an initial booster early on are now like, well, I keep hearing when is enough, right? So, and those are some of the conversations that we have to figure out how to have in order to address this moving forward.
Thank you. Unfortunately, we need to move to the next part of our panel, but you can, of course, reach out to the speakers after this.
All right, thank you. Thanks for the great discussion. I was intrigued by the 18 to 30-year-olds that was mentioned, since I have two of those in that age group. I'm not going to say where they land. All right, so the next session's on communicating biomedical research. We've heard a lot about this over the last day, or yesterday and today, and I even recall Dr. Cohen saying he wishes that they would have done a weekly press conference just to let people know what they were doing from a research perspective. I think that would be fascinating, even with what we've talked about today with the social sciences, about things that Neil had just mentioned, that if you knew that on a weekly basis, you might have changed some of those strategies early on. So I'm going to introduce the three awesome speakers we have for us, and then I'll call each of them individually to give their opening comments. So our first speaker will be Richard Horton, who is the editor-in-chief at The Lancet and an honorary professor at the London School of Hygiene and Tropical Medicine, University College London, and the University of Oslo. Then he will be followed by Stefano Bertuzzi, who is the CEO of the American Society for Microbiology, one of the largest publishers of microbiology research in the U.S., and has led the Society's efforts to address the COVID-19 pandemic. And then we'll be finished off with Kathleen Hall-Jamieson, who is the Elizabeth Ware Packard Professor at the Annenberg School for Communication and the Walter and Leonore Annenberg Director of the Annenberg Public Policy Center at the University of Pennsylvania. So we'll start with opening remarks from Dr. Horton.
Thank you very much. I really appreciate you inviting me to join you. My remarks are going to be based on a report that was published a month ago by Economist Impact, which is the research wing of The Economist magazine. It was partly funded by our publishers. Elsevier and I sat on the advisory board. It was a survey of over 3,000 scientists worldwide on every continent. And the specific question that was asked of those scientists in a survey and then in follow-up seminars was, how did the pandemic affect communicating science and research? Their report was entitled Confidence in Research. I'm going to underline 6 key findings. Number 1, inequalities worsened during the pandemic. Those were inequalities in doing and communicating science and inequalities in access to funding and resources. But these inequalities were particularly bad for 3 groups of individuals who require our special attention. Number 1, early career researchers. Number 2, women. And number 3, scientists working in low middle income settings. Second conclusion from this report was what you've already talked about today, which is the explosion of misinformation. And for these scientists who were surveyed, the importance of giving attention to study design and the importance of peer review when discussing science in the public sphere was particularly underlined as one means of trying to combat this misinformation. A third message concerned the role of scientists in societies. Many scientists came to have a much more public-facing role, explaining the latest evidence in the media, whether it was interventions, new variants, forecasts of how the pandemic was evolving, or countering fake or misleading information. Fourth message was that there was an increased public attention to science, as we all saw, but that did not necessarily mean that there was an increased public understanding about science. And many of those surveyed in this piece of work were particularly concerned about their public-facing role leading to an oversimplification of science in the public sphere. And again, another issue you've talked about already, the politicization of science. Excuse me. A fifth message also related to the greater public attention and scrutiny given to science. Scientists found themselves paying much greater attention to the care with which they presented their work in public, communicating the limitations and uncertainties of their work, not going too far beyond what they could reasonably say. They were very concerned about their exposure and vulnerability in the public sphere. And that goes to the last point, which was in some ways the most disturbing point, and that is that many scientists really felt the sharp abuse from being on social media, where, of course, so much science is now discussed and communicated. And the abuse that they received led to a reduction in the confidence they felt about communicating science in the media. And what they called for, what they wanted, was more attention from their institutions to be taught the skills to be able to communicate their research in that very, very difficult public space. So I think these 6 messages that come out of this confidence and research project do lead to some actions. We need to address inequalities, particularly for early career researchers, women and scientists in low-income settings. We have to do something more about addressing misinformation. We need to think about training scientists for more public-facing roles. And we need to think about what we can do to address the abuse that scientists get in social media. Thanks very much.
Thank you for that powerful message, Richard. Now we'll turn it over to Stefano Bertuzzi from ASM.
Good morning, everyone. It's still morning. Delighted to be here today, and if I can have my first slide. Do I control them here? Perfect. Yeah. Well, this comes, okay, great. Yeah, happy to talk about the communication issues, and given the time, also ASM has been very involved in many different aspects of the pandemic on the front line, on the supply chain issues that we were facing in the network clinical microbiology. I don't have time to talk, it's out of scope for this, but if the forum is of any interest with that, we'll be very happy to provide additional information on that topic. Also, what Dr. Horton just said resonates a ton, and I won't be able to get into details, but if there's any interest, if you go on the ASM YouTube channel, there's a talk that I gave at the ASM microbe meeting this past June. It's exactly on the topics that he touched upon, which resonate with me a ton. What I'm going to be talking then today about, and it seems like this clicker is not working, is that correct? Perfect. All right, about communicating biomedical research. And I was asked to focus on the role that scientific societies can play. And rather than telling you that ASM is the largest publisher of microbiology in the world, that the best science sits here, so you should only, apologies for the Lancet, submit to ASM journals, I can tell you that, while I'm not discouraging in that direction in any way, that we understood immediately at the beginning of the pandemic, I'm talking about week 1, that there was another role that we should take on and that we hadn't done before. and that of being the curators of information. Because we opened up all open access, all our articles, obviously, on SARS-CoV-2, but we felt that there was so much more information and that the issue and the crisis that we were facing was so daunting that we couldn't waste a second, right? And we didn't want scientists around the world to waste a second. And we felt that putting together a platform that would aggregate all the relevant information that was out there to make it easier for people to find what was important, not to duplicate what was already, and also make a connection. We felt that this was very important. So this was all open and accelerating discoveries in a moment of crisis. This gave rise to what we call the COVID-19 registry. And I can tell you that the second week of March, on a Sunday night, we were on a video call with Dr. Harold Varmus and Dr. Lynn Enquist and many others in my team, trying to figure out how we could put this together in no time. Generously, Dr. Lynn Enquist, a notable virologist who was former ASM president, took on the role of being a curator-in-chief, and we put together in no time a team of curators for the various different areas. You probably can't see, but at the top here you can see the basic virology and the various different sectors that we organized the register on, all the way to clinical and application. And Harold was very generous with his time in serving as an advisor in this project. We have posted on the registry over 2,500 papers, and out of 4,600 being reviewed. As you can imagine, this is a lot of work. Imagine if all this is coming to you from the fire hose, right? And so it was a significant job to do this. We were pleased to see that we were having over 150,000 single view visits to the registry every week. And so we felt that there was interest in the community. It was attention. And then we created out of this, to make it even more difficult for us in managing all this, was having bi-weekly commentaries by the curators and saying, what is it the most exciting thing, the most important thing that you have seen, or the things that need to be paid attention. And we also hosted 15 virtual journal clubs where we had over 1,000 attendees from 55 countries. Again, this is an example of how we as professional societies and publisher can add value by bringing the community, the global community, together in a moment of crisis. So I'd like to make two concluding points to this. The first one, I want to touch upon the issue of preprints, and there's value and there's risk here. And full disclosure, I am on the advisory board of bioRxiv, and ASM has been, also in part because of this relationship, one of the early adopters and also innovators within bioRxiv in terms of the relationship with published papers. So we're very supportive of that, and I think they were very valuable during the pandemic, as in general. There's risk. For example, tonight I am hosting a salon with 12 reporters from national outlets on gain-of-function research. And you get it, right? Dual-use research, gain-of-function, all this thing, unreviewed, create enormous problems. And so we're very concerned about this, but the solution is not to have sharing of information, so something to be looking at. And let me put a plug for communicating with the public, which we just heard. And I call it where society meets scientists and where scientists meet society. I don't have time to describe this in detail, but I can tell you that I'm deeply convinced that the colonialist approach that many scientists, and I put myself in there as a scientist, sometimes we have, let me tell you, this is difficult. Let me explain to you how this works. It's such a terrible way of doing it. I was at the Kavli Awards prizes earlier this year in Oslo, and at the banquet, I had to appeal to all my sense of maturity not to jump in front of the king while one notable scientist was speaking and say, don't listen to this, because the message there was, we as scientists need to tell the people what they need to do. And I say, oh, please, we as scientists need to listen. We as scientists need to listen to what society needs. Yesterday, I was on Capitol Hill because Congressman John Larson today is introducing a bill that will make very significant impact on flu, on combating the flu. And there was a brief there. There was the story of a mother who lost her son, 5 years old, to H5N1 flu. That is the message. That is what we scientists need to do. We are here to solve people's problems. We are here to listen to them and to contribute. And very often, I know this sounds like obvious, but sometimes we forget about this. And so since we are at the National Academies, I could not think of Abraham Lincoln. And going back to what he said, that public sentiment is everything. Without public sentiment, nothing can fail. Without it, nothing can succeed. So it is extremely important that scientists meet society and that society meets scientists on equal footing. We're not here to teach, let alone to preach. We're here to listen and to bring our toolbox to be able to solve problems. That's why we're in business.
Great. Thank you. You can, and Stefano, you can join me up here for when we do the questions. So now we'll turn to Dr. Jameson.
Thank you for the opportunity to be with you. And Gary, if you could put up the first slide, please. The keynote speaker opened with the session that included discussion of misinformation, and it's been a theme throughout these 2 days. And I'd like to focus on that specifically. Next slide. And ask whether we could be going forward, think about the principles that would be involved in minimizing susceptibility to misinformation if we have another pandemic. And right now, as we're dealing with whatever we've got going on in the current circumstances with flu and RSV and COVID across the nations, I'd like to argue that we ought to be able to find a way to identify prevalent misconceptions from our COVID experiences, including misconceptions about COVID-19. And a number of people who have participated in this forum have done that with other vaccines in other time periods and have also done this when deal with COVID as well. We need to verify that those misconceptions actually matter, that they are consequential. We ought to identify the evidence and lines of argument that were used to sustain them. And then we ought to ask, could we preemptively, protectively, proactively undercut susceptibility to them? So the question writ large is, can we learn the lessons from the COVID experience and apply it forward to minimize susceptibilities to misinformation? Next slide. In order to ask the question, next slide, we looked at the fact-checked claims by major fact checkers, 3 of them international fact checkers, the rest fact checking primarily in the United States. This is across a more than 2-year period, a 28-month period. There were 4,153 misconceptions. I created factcheck.org with Brooks Jackson in the United States. It's credited with starting the fact-checking movement in politics in the United States, and its SciCheck has been working in the area of science communication fact-checking as well. We can't check 4,153 misconceptions and make any sense to a public with any thought that they will remember anything of what we've done. We've got to have a coherent structure of understanding of the kinds of knowledge that we are deploying in response. And once we are able to do that, we could ask, next slide, can we create a taxonomy into which we could parse the knowledge that we could use proactively and preemptively to minimize susceptibility? Here are the categories into which we parse those over 4,000 claims. Reliably, Krippendorf alpha, 3 coders, over 0.8 reliability in each category. Now, across this, part of what we learn is you've got deceptions in each of these claims, but you can also see pretty quickly, this is what science is asked to answer conceptually when you've got a new pathogen that is infectious. And so if we could think in advance, what are the basic categories of understanding we would like people to have about the origin of viruses, their transmission, their existence, virulence, extent, how we diagnose, test, and trace, how we prevent, how we treat, and what the value is of vaccination when vaccination exists, we should be able to lay down at least some basic protective knowledge. And then on the back end, the fact checkers could could turn to it as a way of clustering all the deceptions into schematic areas of understanding, because they're largely deploying that core knowledge against those deceptions. Now, notice what we see across this more than 4,000 claims. Most of them fall into vaccination, not a surprise. Next slide. And within vaccination, again, we can reliably parse into subunits, but most of them fall into the category of safety. So let me focus in my remaining moments on safety and ask, how would we minimize susceptibility, and now I will say in the United States, to the safety claims that we parsed into these categories? Next slide. And do we know whether they're consequential? Because you don't want to spend a lot of time on claims that just don't matter. Next slide. We identified 9 claims that are prevalent, some of them about vaccines in general, some of them that are COVID specific. And because they were prevalent and in the national probability sample, the United States population, we found that we had enough unsurety, that's the yellow, or wrong answers, that's the red, although we did see a high level of science-consistent answers, but enough unsurety and misinformation, basically active acceptance of misinformation, to suggest that they could be worrisome. We then began to look at them across time and look at their predictive pathways. Now, notice you see some of our old reliables there. MMR vaccination, autism, more vaccination, autism. If we could have gotten ahead of those initially, they wouldn't be sitting there trapping every new vaccination that comes along and seeding misinformation susceptibility about it. But we've also got vaccines have been responsible for thousands of deaths. Hold that for a moment, because I'm going to talk about how we can minimize susceptibility. Vaccines cause infertility. It's safer to get the COVID vaccine than to get COVID. You see some of these are phrased negatively, some positively. Vaccine changes DNA. Allergic reactions to authorized vaccines rare. Getting a flu shot increases risk of contracting COVID. And then you've got vaccines given to for MMR vaccine caused autism. Increased vaccinations are why we have so much autism, and the vaccine in general are full of toxins and harmful ingredients such as antifreeze. Those are all safety. We tracked them through our surveillance tracker and found that they were viral and widespread in the United States. Our survey says they've gotten enough traction to be worrisome. Next slide. So we looked at them across time, and we found that acceptance of these forms of misinformation, or the absence of the knowledge, or correlatively the presence of the knowledge, would predict in the opposite direction. The acceptance of the information was increasing hesitance among adults, and also adults' willingness to vaccinate children. And what was interesting about this was it increased not only adult hesitance about self, but among vaccinated adults, it was increasing hesitance. So we had vaccinated adults who were parents whose vaccination hesitance about their children was being activated in some way by these that would suggest that it had traction for them, in particular as they thought about children, but it hadn't stood in the way of their own vaccination. Next slide. And so we concluded that they're consequential. What we showed in the article is that you increase the likelihood that you accepted one, you decrease the likelihood that you would vaccinate. Next slide. So if we know that they're consequential and we can find them and they fall into a safety category and we know that it matters, let me talk about some kinds of ways that we could have minimized susceptibility. Next slide. Here's VAERS, the Vaccine Adverse Event Reporting System, and just some of the deceptions that were seeded by it. We know that VAERS was also the source of misinformation about virtually every other vaccine that we've had since VAERS was inaugurated. It was in particular a hotbed of activity over misinformation about the supposed vaccination autism correlation. Next slide. So here's Robert Kennedy Jr. Notice he's presenting to a state legislature, and what's his source for that false claim about deadliest vaccine? He's citing VAERS data. Next slide. You also see a U.S. senator doing exactly the same thing. Next slide. Here you see a popular Fox News host doing exactly the same thing. So what's my suggestion? Let's do something simple. Let's change the name of the Vaccine Adverse Events Reporting System so that you don't make the assumption by virtue of the name that the event is caused by the vaccine. Next slide. We need to preemptively find a way to undercut the susceptibility. Next slide. So change the name of VAERS, but while we're waiting to do that, make VAERS synonymous with the word unverified. And also, another point, to take the general category of vaccine safety, every time we make a claim about vaccines, make sure that we make the claim that the benefits of the vaccine outweigh the risks, thereby acknowledging there may be some, so that when a side effect occurs, We have that line of argument in place already. And we have also an understanding of how the certification process works within countries to establish that the benefits of vaccination outweigh the risks. And then secondly, don't say vaccines are safe. That's heard as categorical. Vaccines are safer than getting the disease. Next slide. Now let me turn back to VAERS. I would change the name of VAERS to call it a vaccine safety monitor or a safety watch or a safety sentinel. I would stop priming the negative association adverse events. I'd prime safety, and I would disassociate vaccine from presumed, confirmed, and adverse events in process. Please find a way to change the name of VAERS. Next slide. The description, that is the subtitle of VAERS, should be tied to VAERS every time VAERS is used. That suggests it's a monitoring system. If we could just get monitoring in place as a subtitle until we get the name change, we would be somewhat protective. Next. We also need to say VAERS equals unverified. VAERS equals unverified. So people see the V and they hear unverified. If we could just say, anytime someone cites VAERS, unverified, the public hears unverified, you could knock down every one of those deceptive claims that took anything that was logged into VAERS and said it was causally established to have been caused by vaccines. Next slide. Summary slide. Next slide. Funding disclosure, Robert Wood Johnson Foundation funded this. The views are mine, not necessarily theirs. Next slide. Thank you to the Annenberg team that made all this possible, and thank you. Take down slides.
All right, that was fantastic. Thank you all of our speakers, and you guys were quick and right to the point, so I appreciate that. I think one of the big things with this is we really want to understand next steps for improvement in this space. Now, I think Dr. Jameson gave us some big next steps around VAERS. I don't know, Dr. Jameson, if there's any other big next steps you would like to add to changing VAERS.
No, I think the most important thing that we could do is ensure that when you see a recurrent pattern of evidence of deception. So what I'm arguing is there's a pattern to the evidence being used. It all ties back to VAERS. We need to identify all of those and say, how could we make sure that that pattern of inference is interdicted? And I see that Heidi is agreeing on VAERS. I think everyone in the community ought to be out there aggressively saying, secondly, let's just get the name changed, because the name itself constitutes an assertion of causality.
Great, thank you. Dr. Horton, next steps for improvement of communication of biomedical research.
Yes, well, as I think I was trying to indicate, I think that one of the things we need to get at is addressing some of these inequalities that are already very deep. Early career researchers and women in particular in high-income countries, I think, suffered greatly from online abuse and the difficulties they faced communicating, doing research, and getting resources for their research. So what can we do in the future to protect their interests? This issue of misinformation, I think, is a bit more difficult than changing the name of a monitoring system, if I may say. The issue of misinformation, we have a muddled concept of truth now, and the idea that we have a marketplace of ideas, that if we can just pump better information out there to address bad information, that's going to solve the problem. I mean, that's just a fallacy. We don't have a marketplace of ideas. We have very powerful social networks where you have, when you introduce a belief into those social networks with different degrees of mistrust about the source of that belief or the belief itself, can lead to rapid polarization. And that polarization overlaid on a very, very severe human weakness, which is conformity bias. Unfortunately, we tend to believe people too much, creates an absolute perfect space for the propagandist. And so how do you address the propagandist in a space of a social network that is almost the perfect fertile area for spreading misinformation? It's a much more complicated problem than I think we've been saying so far, if I may say.
Thank you, Dr. Horton. Dr. Bertuzzi, best next steps.
Well, I would say that the issue of engaging scientists and society in a different way, we really need a forum that allows this conversation to happen that goes beyond the choir. I feel that when we talk as scientists, we talk to the New York Times readers, the NPR listeners. We could be speaking gibberish and they would clap. But unfortunately, we are in an echo chamber there. We need to speak to the people, to society. And that goes to the issue of diversity and inclusion. To me, that is the core of it. And so I don't know, but turn on CNN, turn on any channel, you're going to hear on a regular basis economists talking about the economy at any time. Why do scientists get called in only when we have a crisis? Do we call economists only when we have a recession?
Great, thank you. I know the last session before the break, we ended very quickly. I don't know, Naveen, if you'd like to come back up and chat. There is a question from the audience, but I'll ask one more for the current panel. What about these other non-peer-reviewed avenues of communication? Twitter, Facebook, where obviously even scientists have gone to Twitter more and more to talk about our papers. How does that influence, and how do we, whether we leverage these avenues? And I think, again, I'm back to Heidi talking about the 18 to 30-year-olds, and you can't say TikTok and without thinking of 18 or maybe even younger. But either, how are those going to influence as we get, in biomedical research communication?
Can I jump in?
Yes, please.
Again, I'm on record for being not a big fan of social media. I think that while they provide, or in theory, they could be a phenomenal way of democratizing information that goes beyond a few outlets that control what's being said. They could have provided a phenomenal lens for everyone to focus on something that's close to them, that's relevant, that may have been missed by others. Unfortunately, this lens is completely shattered, and now we live with the whole world yelling at each other from one of these little fragments of the shattered lens that doesn't allow us to understand close to nothing. And I think that I am not a fan of social media, in case you were wondering. And we use them, of course, but again, I could speak for hours on this because it's a topic very close to me. I would just quote the article in The Atlantic this summer on this, where it's really making the point that if you ever wondered how it was living in the Tower of Babel, that's probably where we are right now with social media. And the title of the article was "Why the Past 10 Years in U.S. Communication" or something in the U.S. have been stupid.
Kathleen or Richard, anything you want to add?
Yeah, let me just say that Professor Larson has been telling us for more than a decade, importantly, how important trust is. One of the ways in which you respond to ideological cues that are polarizing is to find ideologically congruent communicators who are trusted, who create counter cues. So when evidence that Donald Trump took the vaccine, although he wasn't publicizing it, is put into an experimental context, it does move conservatives.
Mm. Yeah, and I would also just say that certainly our experience in the United Kingdom, there were reasons why the public got confused at certain times because scientists disagreed, and science wasn't one monolithic point of view. And you would have people on news media, for example, debating whether children should be vaccinated or not. And scientists, reasonable scientists, took a different point of view. And you saw different policies in different countries in the world about that particular question. And so the public, not unreasonably, got confused about that. Should schools stay open? Should schools close? People got confused. The evidence on whether masks worked or not was difficult to point to in the early months of the pandemic. And then when the trials did start to come through, they weren't particularly good studies. So again, it was difficult to have a discussion in the public sphere about these issues with any reliability. So I think when we're looking at public responses, it's not unreasonable that there was a lot of uncertainty at times. So I would be a little cautious about being overly critical.
Thank you. Audience member?
Hi. Eva Harris, UC Berkeley, and the FMT as well. Okay, so it always comes to me to bring up difficult topics. So I struggle with this a lot. I work on dengue, and there are real issues with the vaccine. Our work in Nicaragua over 35 years has actually shown that this antibody enhancement does exist. It happened with the first licensed vaccine, and it's about to happen with the second licensed vaccine. And you know, so I feel like, and there were some issues during, as you know, Richard just mentioned, there was uncertainty, there was some issues with, say, like the J&J vaccine. And when there are actual real issues, how do we communicate this? And this is what I was going to bring it up actually for the last panel too, because I feel like if we just gloss over when there are, I mean, a lot of that is crap, excuse me, like the stuff that we just looked at, those are not true. But when there are actual risks, and scientists deny or just gloss over it because we don't want to mess up the, you know, of course I'm pro-vaccination, of course we need vaccination, but I feel like there's a very difficult, uncomfortable space, which is how do you communicate when there are actual risks in a way that is not going to be just jumped all over. But if you don't acknowledge it, then you might lose trust in scientists, and so I really struggle with this, and I wonder, you know, both from both of the panels we heard this morning, how do you deal with this?
The beauty is we have all three panels. I think Naveen, you want to go ahead and go first, I think?
So you are right, and first thing is you have to be honest and transparent. You know, that's what we said, that you have to learn how to convey uncertainties and how to convey risk. And I'm telling you a very, one example. My nephew called me that vaccine is available. Should I take it or not? I said, but do you know there is this VIT happening and all that? Yeah, but that is less than what the COVID is, So they understand. But if you play around the words, if you are not transparent, you don't answer very, straightforward, make it complicated, they are confused. So they are ready to take risk. He was a young guy, and who said, okay, I know, but I have seen in family the people suffering from COVID and they got serious. So it is definitely the risk is. So it is how it is not important, as I said, Professor John's quote, it is not important what do you say, it is more important how do you say.
Neil?
Yeah, I'll quickly chime in here and echo the point on the importance of transparency in these discussions. And I'll go back to the example of the J&J pause, right? That was a moment where there was an opportunity to have a conversation about how good the process is, that millions of people were fine, that a few had these adverse side effects, and we stopped it to make sure it was going to be okay before we would continue, right? Like that's a moment where, it was, it raised a lot of anxieties when the pause happened, but you have a transparent conversation about like why this is being stopped. What does that tell us, not just about that vaccine itself, but the process of that's in place to make sure these things are really safe before they're unleashed to the public. Like I think that kind of transparency really builds trust in the process for future things. Yeah.
Any of our panelists on Zoom want to speak to that question?
One of the problems with the J&J pause was the media was verbal, not visual. So when the media did in headlines include at all the word rare, it was the word rare. And rare doesn't mean to people when they hear the word rare as it actually is when you graphically illustrate what it looks like to say 1 million people. And these are the little dots out of the 1 million people who were affected. Also, we did not effectively communicate that the FDA's pause resulted in specific kinds of guidance to doctors about to watch for and a recommendation to take the other two vaccines that were not causing the problem. So it's not simply disclosure about the science about the vaccines, but the processes by which we know what we ought to do given the best available evidence, assuming that we still have trust in the agencies that are offering them. Separate problem, of course, those agencies' trust was systematically attacked by some people on the right during the pandemic.
Great. Okay, so we're at 11:30, about 11:35. Just want to thank all of the panelists and coming back up to answer. Oh, go ahead, Chad. Sorry.
Yeah,
please.
I just wanted to sort of answer that question, but bring something up that I've heard this morning, and it may be a little bit provocative, but based on a statement that Stefano made, don't tell me how to do it. Don't. As a clinician, I don't want to be told. I want to be given the information in order to communicate. And we've talked. A couple of things have resonated as potential things that we could do going forward. One, teach clinicians to be better communicators. I'm not offended by that, but I guess what I would say to that is, give me something to communicate. If I can't communicate, so the FDA approved the bivalent vaccine for children down to 6 months old this morning. They approved it based on 56 study participants. That's not information that I can use to convince somebody to get a vaccine. That's not good enough. And there's numerous examples of not good enough throughout this pandemic of where is the data. When I listen to people from Lancet and from the microbiology publication, I look for sources of truth. I expect research rigorously looked at and defining evidence that I can then communicate to a patient or a caregiver on why I'm going to do something. I can't go on speculation or narrative or politics. And I think that's what we're missing here. You know, changing the name of VAERS to something else will be as effective as changing global warming to climate change. It's not going to be all that effective if you don't deliver information from those sources and respond to what might be considered misinformation. I'm not a big social media person either, and I don't think that social media is a good place to debate some of these issues. But this has been going on for 100 years. We had the yellow press at the turn of the 20th century in the 1900s. People get information from various sources. It's not always good information, but what usually resonates is truth. If you tell me the truth and it's convincing, I will follow your recommendation. We've done a bad job of getting to that truth. Just again, the FDA approval. How can I explain to somebody that bivalent vax is going to be effective for them and safe for them based on 56 individuals? Where's the risk? I know risk exists, and again, this is my population, so maybe I'm a little biased. I know risk exists for people over the age of 65. I can point to it, show it, identify it in death counts and case rates and hospitalizations. That's an easy thing for me to convince somebody to do. I can't do it for some of these other age groups, and it comes down to not having the data and not having something to communicate that can be effective.
Heidi, I think I'll give you the last word since I heard you wanting to speak there. So if you want to go ahead and end us.
No, I would tend to disagree that we don't have some, I don't know about changing the name of VAERS, but it's not, if you want the truth, people are misinterpreting it and calling it truth. I mean, we should at least, I think one of the things Kathleen had talked about is unverified or somehow framing it, because it's really causing a lot of problems. It's used as data. We've seen it. HPV is another vaccine that has suffered tremendously because HPV has more reported adverse events than anyone, and that's how bad it is. Well, no. So I don't know what I'm not saying changing the name alone is going to do it. And in fact, there's been some interesting research that compared the standard kind of quasi-promotional leaflet you get in the clinic about a vaccine that is more focused on the benefit than the risk, giving out that plus a little bit more from the safety risks and all that, and then giving them the VAERS files. And what they found is that giving them more than that kind of quasi-promotional leaflet and acknowledging that there are some risks actually improved people's trust and willingness. But when you give them the VAERS files, they're like, whoa, too much, I'm not going there. So there is, and it was a pretty good study, and I would agree with that. But I do think we have a real issue with the way VAERS is presented, and it's really caused a lot of harm.
Well, this is a great conversation. I really appreciate it. I think we could go hours just going back and forth, which I think is what we definitely needed for this session.
Richard did have his hand up.
Oh, sorry, Richard. Go ahead.
He usually has wisdom that we could leave with, unless he got.
I think he might have a hard
I think
stop.
he left.
Okay, he left. All right. Well, thank you, everybody. We'll have lunch now. I think we'll reconvene here back at 12:25. So enjoy your lunch, and thank you to all of our panelists. Great job.